Thanks to Dr. Johnson, moderators, Dr. Neha, Dr. Sachin, Dr. Arpan for keeping Pathoindia to what it is and constantly thinking of new things to be done. It was a pleasure to see the earlier PI talk series by Dr. Divya Sharma on lung pathology. And this is the second one. So I thought, let me share with you and learn from all of you about digital pathology. Dr. Kim is here, and I just had an opportunity to chat with him, and I see that they're way ahead in terms of what's coming up in the future of digital pathology. But what I would like to do is take you through some of the experiences that we have had over the last 10 years and see if we can kind of tag it or integrate it along with the survey that we had over the last 1 or 2 weeks. Some housekeeping instructions. All participants are requested to stay muted. Turning on your video is optional. If the presentation is inconsistent, it may be due to low bandwidth. It is advisable to turn off your video to make the experience better. For questions or comments, please use the chat function. Raise hand function can be used after the presentation, and if time permits, we can have some discussion one-on-one. This session is being recorded for future use on Pathoindia platform and for continual improvement. If you have connectivity issues, please log out and reconnect using the link. Most problems get resolved in this manner. If the problem persists, please type in the chat box and address it to Pathoindia participant, because that is being controlled by Dr. Johnson, who can help us.
Yeah, sure.
And this presentation is for about an hour, including questions. There will be no break in between. With that, I'll take you a brief on disclosure. I have no conflicts of interest to disclose. I'm learning digital pathology as we go on this journey. I'm still a student, and I'm trying to share experience over 10 years and some from literature. Concepts are evolving and need to be tested and experienced to see its value. And some images taken from the internet are used for educational purposes only and are duly credited to their respective owners. No commercial use is intended. Like I said, this is for about 60 minutes, and with a brief introduction, a little bit of historical aspects, but I think this I'm not taking upfront. It will probably come later. Applications of digital pathology, take some questions. I'll summarize and see if we can take some questions and learn from each other. So when we talk of any topic introduction, we generally want to discuss what, when, why, how, where, and which of the subject. I'll start with what is digital pathology, and if you look at the typical definition, it's digital pathology, which is a process of converting analog information to digital one in pathology environment. And this is coming from Royal College of Pathologists. And they go on to say that it includes acquisition, management, sharing, and interpretation of pathology-related information. And this next sentence is important. This includes slides and data in a digital environment. So when you look at the definition, it has kind of a wider implication rather than just looking at whole slide imaging, which we as pathologists or purists are comfortable with. So I would take you through digital pathology beyond the whole slide imaging as well. So when you have a glass slide, or let us say we even have a rapid card. Many of our labs in India use rapid card tests for rapid diagnosis, or we have a handwritten text. We need to convert these into digital data, and we have tools to do that. We have a whole slide imaging device that can convert the glass slide to a whole slide image. We have document cameras that can convert in a device into an image or a text into a digital image. Now to that digital image, we can get in a laboratory environments, we have many equipment which starts sending numbers to the same kind of database. And we can also have images like scatter plots or electrophoresis graphs, which can then be converted to digital data. Now, all of this goes to the pathologist. Now, the pathologist typically sees them and makes sense of them and interprets them. And it's also possible that they can share it with another pathologist or even try to use machine learning to understand if it's big data and the pathologist or humans really cannot make sense of big data. We make use of AI, machine learning or deep learning. And that output has to go back to the pathologist to understand if the input or the source specimen or a test device is actually relating to the output that is being given by the machine learning. So we are having raw data that gets converted and digitally organized and subsequently interpreted. When we look at this entire piece, it actually resides there to provide a meaningful report to the patient or to the clinician. But this is coming right out of the specimen that is provided to the lab, which then gets converted to a digital setting. And obviously, the starting point is a patient who is the central piece, who would be giving the various specimen for examination. When you look at this entire piece, it is obviously sitting, residing within a bigger aspect of management, including early detection, prevention, treatment, and the patient is part of the community. And when you look at the output of the prevention, management, and treatment, it goes back to the community. So it's like a cycle of how meaningful whatever we are doing in the lab, whether in this context we are trying to use digital morphology to kind of make it more meaningful. So you have a glass slide and we have a microscope. And we have our vision to look at it under the microscope. This is conventional microscopy. But the same slide can be put into a box and then can be made available to be seen as a whole slide image on a computer screen. And that gets to become digital. So you have a digital pathology coming not as a replacement to the microscope device. So the whole slide imager has a microscope built within. So we can't do away with a glass slide. Now, both, whether the microscope or the whole slide imager, they are basically tools that provide the pathologist with a view of the section that is being examined. I'm extending beyond slides. So this is where I was talking to you about a rapid card test that is typically viewed grossly, macroscopically, and conventionally, and a record is made of its the result, whether it's positive or negative. But if the same thing is imaged and taken into the laboratory information system, and that can be converted into an analysis and be seen on the computer screen. Now, this also is digital. So we have digital pathology that uses the tools, but now with computational pathology coming in, the whole slide image is being examined or studied by machine learning techniques and the output of the machine learning. Of course, for a machine learning, there has to be a question asked. What are we expecting the machine learning algorithm to, what is the question that is being, what are we expecting from the machine learning? And that's where the insight will come. And the insight will be taken up by the pathologist and made sense of. So we have computational pathology coming right after digital pathology. So when we look at the fundamental differences between digital radiology and digital pathology, digital radiology happened very quickly. The transition was much faster. And the moving from film to digital was natural because they were viewing static images of X-rays or CT scans. It was easy for them to move that image onto a computer screen and see it on the computer. The other big difference is that it eliminated the film itself. So the earlier manual processing of films, handling chemicals, all of those just disappeared. And it was a cost replacement in digital radiology. It actually resulted in cost reduction. Whereas in digital pathology, it's an added step to convert a glass slide to an image. All the steps to prepare glass slide continue to exist, and there is an added cost of converting that glass slide to a digital image or a whole slide image. Of course, things are changing. We will see more technology coming in future, but this is a fundamental difference between radiology and digital radiology and digital pathology. It's like looking at an e-book versus a printed book. But the difference is e-book can exist without the print book, whereas a digital slide cannot exist without the glass slide, or I mean, cannot be prepared or cannot even come into existence without the glass slide. So by definition, digital slide is an image version of a conventional histological slide. There are many differences coming to storage, portability, cost. Cost is a big thing because to convert a glass slide to a whole slide image is capital intensive. The cost of storage needs to be factored because our journey over the last 10 years, cost has become a big hurdle. Whereas in a conventional slide, it's only cost of preparing slides. Of course, the downside of a typical glass slides are many. The speed of converting the glass slide into whole slide image and actually reading it on the internet. The look and feel of the virtual image versus the feel of the microscope. I think this is more to do with a pathologist's mindset and durability. Once digitized, the slides are extremely durable unless it gets corrupted. Of course, you need to have a backup of that. Sharing across geography is very easy with the digital slides, whereas the glass slide needs to be couriered and it takes time. The resource required, if you observe here, in both digital as well as conventional with pathologists is needed. And I really do not see in the near future pathologists kind of being replaced by digital pathology, computational pathology. Of course, it will make many tasks easy. For example, counting mitosis or even scoring immunohistochemistry. If it has already started to happen, it becomes much easier. But the pathologist is still needed to put all that information together and make sense of it, which again, if the human can do it, AI can do it over time. But it is a constant movement towards that, during which time I would think the pathologist has to start adapting to the changes that is happening around the world, particularly in the laboratory environment, and start to reinvent himself or herself to find ways to be to actually improve over what the AI is doing. So Now I'll take you through the questions which we had during the survey. And the first one was, how familiar are you with digital pathology? And we had 51 responses, and I was really happy to have them. And if you look at the familiarity, and it was really nice to see that almost 90% were familiar with digital pathology. And that is really good to see. And this familiarity comes from probably seeing whole slide image during slide seminars or even proficiency testing or during conferences and demonstrations or even routine reporting, teaching, consultant archiving. The good part is compared to 10 years ago, I think even in India, we have a good number of labs that are practicing digital pathology for various reasons. Of course, the uptake is slow, but I think the adoption is much faster now. The second question was, which aspects of digital pathology are you most interested in? And this was, for me, a good one, because most indicated that the image analysis and AI integration, most of them kind of related to image analysis and AI integration. And that was the interest. So when we look at image analysis, one would want to make it easier to measure the depth of invasion or do measurements easily. On the microscope, of course, that's challenging, but now it becomes much easier because you have tools to even start looking at the worst pattern of invasion and start measuring the distance as well. Now, I'm deviating from a typical whole slide image to a hematology environment where we have a device that images blood smears. And when we look at a smear like this, I'm sure you would appreciate that there are target cells. How many? What's the percentage of target cells? I don't know whether it's clinically relevant, but when you click on target cells, there, it makes it easy for you to even measure the number of, or look at the percentage of target cells, and it highlights all the target cells that are there for us to visualize. Now, this was a case of thalassemia trait, and when we did hemoglobin electrophoresis, the A2 was clearly elevated at 5.4. But not only that, the digital conversion of an analog smear provides for viewing the cells in a very efficient way. And if you look at this, it kind of converts the images, classifies them, and provides differential based on the images. Of course, it may not be accurate. The pathologist still has to view it and see what these cells are. And based on the experience, understand the nature of the cell, in this case, a promyelocyte with a lot of OR rods being very visible. So image analysis and AI integration will certainly be a big interest area for most pathologists. Workflow efficiency and automation will be there. And going on to the next one is, what is your primary motivation for adopting digital pathology? And if you look at the answers, it was interesting to see that everyone was motivated in one way or the other. There was not a single person who said not interested in adopting. Probably 5 years ago or 10 years ago, there would have been some skepticism about getting towards digital pathology, but I think that has disappeared now. And the biggest proportion of answers coming more than 50% was coming from staying updated with technological advancements. Now, this is interesting for me because if we are using microscope right now for diagnosis and you're staying updated with the technological advancements, clearly the reason why we are doing that is to go to the next level of using digital pathology, say, to increase workflow efficiency or even to improve collaboration with peers. I think that's very important because that will bring us to many aspects of what's happening currently and in digital pathology. While just before we started the seminar, Dr. Kim Soles was talking about how digital pathology has gone so forward that there are many aspects getting into automation, doing much better than humans themselves. And that can be really an area of potential improvement. So in Michigan, University of Michigan, preparing for and deploying all digital workflow at significant scale is itself a big study that is happening. And I'm sure that will get converted and be actually implemented. Or if you look at this, I was really surprised to see that he's talking about slide-free, label-free, pain-free pathology. And I really don't know, and I'm not going there. I just wanted to put this slide for you to even get an idea of slide-free digital pathology. The next question, which digital pathology tools or systems have you used in practice? And this is something that I wanted to know how it would be. So obviously 35% are talking of whole slide imaging. But what I was surprised was 30% have mentioned that I haven't used any digital pathology tools, because these tools are many and they're ubiquitous. They're probably there in your lab, but we just don't see them as tools. Whole slide images, digital microscopes, image analysis software, or AI-driven diagnostic tools. All of these are probably tools that we will be using more in the coming years. And if we don't, then the amount of data that needs to be interpreted can be overwhelming, and it's really difficult for us to complete our work. The next one was, how do you perceive the accuracy of digital pathology compared to traditional methods? And I was actually looking forward to the answers on this. So we had choice as much less accurate to much more accurate. And the extremes of obviously are smaller percentages, and most have just mentioned slightly less accurate. Of course, this is a very subjective perception because it depends on at what level of maturity is the AI algorithm to provide a comparison with the human diagnosis. Again, I bring this example. If you've seen this, if you are looking at this image of peripheral smear, you are seeing a lot of spherocytes. Question is, how many spherocytes are there? And if you click on the spherocytes, it highlights all the spherocytes. It's about 20% is what the algorithm is giving. But when you really look at the background, there are many more spherocytes that are not picked up by the algorithm. So it is important for us to understand that if the algorithm of the whole slide image or machine learning tool provides an output, please do not take it at face value. You have to do your validation before you can start trusting the machine learning algorithms. And this should be a constant monitoring of how the machine learning actually came to an outcome. And for this, I think currently explainable AIs are in place where you can ask the AI algorithm on what or how did it come to a conclusion whether it was an image or a scoring, you can ask the AI to provide an explanation. And I think there are ways it can provide you, and on what basis it has provided you with that outcome. The next one is, what are the main challenges you face when considering implementation of digital pathology? And this was, again, I think as expected, the high cost of technology was the most common, more than 50%. The second one was lack of training and expertise, but this is a relative one because as we go along, one will start using it more often because the environment will be all digital, and you are kind of forced to adapt to the digital environment, whether it's a digital slide or an image, or resistance to change from traditional methods. But I would think this would be less and less as we go along. The resistance will change to acceptance and start to work with the digital tools. How do you see role of AI in digital pathology in the next 5 years? I think most, and this is what I expected because I'm of this view as well. It will be a supporting tool for pathologists. I don't see it replacing pathologists in the near future. But if you look at the fourth choice, potential to replace certain tasks performed by pathologists, and I think this is already happening. If we had to eyeball an immunohistochemistry scoring of HER2 or ER, PR, it would take a lot of time and the subjectivity would be much higher. But if you allow the algorithms to start evaluating these immunohistochemistry images, there would be consistency. And if the learning technique of the algorithm is efficient, then it will become accurate as well, apart from being consistent. So I think a supporting tool and replacing mundane tasks for the pathologists. Okay. With this, I'll just share with you the Gartner's hype cycle. I don't know how many of you have had a look at this. This is an interesting one, the concept. Any new technology starts with a technology trigger, goes on to peak of inflated expectations, and then comes down to the trough of disillusionment and moves to slope of enlightenment and plateau of productivity. Keeping this in mind, if you look at the hype cycle of top 50 emerging digital health trends, apparently digital pathology is sitting in the trough of disillusionment as we speak. And this is what I got from ChatGPT. Can you let me know where in the Gartner's hype cycle is digital pathology, is what I asked, because I couldn't put my finger on that aspect. And this is what it mentioned. It said in Gartner's 2024 hype cycle, digital pathology is positioned in the trough of disillusionment. This phase indicates that the initial hype surrounding the technology has waned, and the industry is now focusing on overcoming practical challenges and integrating digital pathology into clinical workflows effectively. This stage is crucial for refining the technology, understanding its limitations, and exploring real-world use cases such as AI-assisted diagnostics and whole slide imaging. If you look at this, I'm sure this will be sitting on a spectrum of situations where on one end is simply amazing maturity of digital pathology. I don't think it would be a disillusionment there. But certainly on the other end of the spectrum are areas where the challenges that labs face to even consistently use digital pathology are still there. So the technology is evolving towards a plateau of productivity where adoption will stabilize, and the benefits of digital pathology such as enhanced workflow efficiency and AI-driven diagnostic support will be more widely realized across the healthcare system. So this suggests that while full adoption is not yet widespread, mature laboratories that have embraced digital pathology are already seeing significant benefits, particularly in terms of diagnostic accuracy and operational efficiency. I think this is something that we have to, it's understandable, and I think it is happening. It's just that we need to experience it. So just a few images of my colleagues going about doing their work in the digital environment. Of course, there's a microscope there. The next question is, have you encountered any barriers to adopting digital pathology in your institution? And I think the biggest one was that of the budget constraints. I'm sure this will be there for a long time till the technology actually becomes more accessible to small and medium-sized laboratory. The good part is startups are coming up in the Indian environment as well, where low-cost imaging solutions are coming up. We need to see how that can get integrated into our workflow. What training or resources would help you feel more confident in using digital pathology? I think there were options of hands-on workshop, 39%, online courses and tutorials was the next one. So obviously, people are looking for exposure to digital pathology in various formats, and I'm sure this is going to happen more often. The annual conferences, whether it's the regional chapter conferences, state chapter conferences, or the annual conference, there are sessions on digital pathology over the last 2-3 years, and it's really nice to see participation in these sessions as well. How likely are you to advocate for the adoption of digital pathology within your department or institution? I think this is good to see. A very small percentage, only 1% out of 51 actually mentioned very unlikely. Nobody at unlikely. Most of them were actually likely to suggest adoption of digital pathology. This is encouraging because I think we are in that direction. I don't think we can go away from the fact that digital pathology will be used more often in the coming years. Which platform do you prefer to engage in online pathology discussions? I think it turns out to be Zoom, and probably one of the reasons why Dr. Johnson considered Zoom as a platform for us to discuss digital pathology. Your workplace is located in which part of India? I think you had a good representation from south, north, west, a little from east and outside India as well. And it is good to see that most gave consent to publish the results of the survey, though it's a very small number. But clearly, acknowledgement will be given to all those who have participated. So when you look at milestones in digital pathology, and it's in 1600s, the compound microscope, Furchow develops this concept of cellular pathology. Of course, those are not digital pathology, but they were essential to even be converted to digital formats. It was in 1968 that the telemedicine project using black and white blood smear images from Logan Airport to Marsden Hospital happened. And in 1986, the word telepathology was added to the dictionary and the patent filed. And James Backus designed the first commercial slide scanner. And if you look at this article in overview of telepathology, I think there are many interesting highlights. Hardware for a complete telepathology system became available in 1994. AFIP static image consult service started. I was not aware of this at all, that consult were being provided on static images. Because the big concern is the static image actually representative of the disease process? In 2000, the whole slide images came to the market, and the US Army converts to whole slide imaging in just 5 years. From the time the whole slide image came to the market. In 2003, we actually organized IAPID, International Academy of Pathology, Indian Division, 6th Annual CME in Bangalore, where we had participants having CRT monitors. And we had Dr. Achyut Bhattacharya from the US and Dr. Sangeeta Desai from Tata Memorial Hospital in Mumbai participating in this session. In fact, Dr. Achyut Bhattacharya had carried with him whole slide image on a hard disk, which it was like magic to see how the digital image was being zoom, pan, tilt, all of those that was happening. And you can see the CRT monitors there, bulky monitors that were being used at that time. And the highlight of the CME was technical advances of telepathology at that time, existence of whole slide imaging, and the ability to share virtual slides. And we understood that it was not a replacement cost like a teleradiology or a digital radiology. So we did a lot of activity in that particular CME. So in 2003, when we organized this, we thought in another 5 years, by 2008, all of us will go digital. But it was only in 2013 that we actually got our first scanner. And digital pathology was discussed in very few CMEs and conferences at that time. It was not practiced in India, and internationally, few centers in Asia and Europe and US were practicing digital. Theoretical knowledge was evolving. The practice was lacking as it was a novel process at that time. And we had this glimpse of digital pathology in 2003 on the virtual slide. So we decided to invest in a digital scanner. Why did we do it? Because it was fascinating to see a mimic of the glass slide experience on the computer screen. And at that time, digital pathology was a luxury, but it promised to be a great tool for improving efficiencies, or that's what we thought. So we decided to purchase a scanner in 2013 to introduce into our reporting workflow. The reasons we got digital pathology in 2013 were not related to commerce or finance or revenues. It was purely passion, inquisitiveness, and the urge to need to do better. The return on investment was never a reason for procuring digital pathology at that point in time. Why digital pathology? It appears to be a step in the evolution of pathology practice, particularly surgical pathology and clinical pathology. Now you have hematology and many other fields in laboratory medicine that will start using digital images. So digital pathology is a disruptive technology, and unlike digital radiology where films are redundant, in digital pathology slides are the basis. And I would think the strongest ROI justification for digital pathology are improved quality of healthcare. There can be discussion on this. People might actually question how can it be improved, and we can have a discussion on that. Increased efficiency for pathologists. This is again a debatable point as of now, because I have experienced this in our own lab where whole slide images actually increase the turnaround time initially, and we had to go back and review the workflow to actually make it better. Reduced costs of handling glass slides. So it's not about reduced cost of preparing glass slide, it's reduced cost of handling glass slide, whether to courier it to an expert or for second consult. Use of digital slide is that much easier. And the most important thing in my mind is all innovations that happen will happen on a digital slide, whole slide imaging. So that will be the strongest return on investment justification for digital pathology. Just a few images for you to see how it becomes easy. And a renal biopsy in which serial sections stained with different stains can be synchronized and examined. It gives a much easier, it's easier on the pathologist to look at the images and come to a diagnosis. So just to share with you, a 55-year-old male on examination, massive splenomegaly. An elderly with a massive splenomegaly, I think you already have a diagnosis in your mind. Let's see if the cell counts kind of did not really flag blasts. There was monocytosis, but hemoglobin was 14.1 and WBCs were 4,440. Platelets were 64. So there's thrombocytopenia. And when you look at the scatter plot, of course, again, my colleague looking at it, when you look at the scatter plot, the cell populations are nicely scattered, clustered and separate from each other. but it's important to see how it would compare with the normal, and that's on the right hand side, a normal scatter plot. There are subtle differences, and the differences are more like how far they are from each other and how they would be from the centroids. And in another scatter plot, it's important to see a particular population doesn't exist in the normal, whereas in the patient had those population of cells which on the digital morphology were looking like these cells, which are basically medium to large size, moderate to abundant cytoplasm, mature appearing nucleus, and projections from the cytoplasm. So this turned out to be hairy cell leukemia, which kind of, when we integrated with all the digital formats, we were wondering, can we alert the pathologist when there's an abnormal pattern on scatter plot? So this also, in my view, is kind of a digital pathology practice that helps improve. We have given this as a project to data science. We have a data science department in our lab, which does image analytics, looks at patterns of scatter plots, annotation with final diagnosis, and we are intending to develop an algorithm to screen scatter plots for known abnormalities. This is another case. I think this is the same thing which I showed earlier. A lot of spherocytes, and when we looked at it, we did an EMA, eosin 5 maleimide for spherocytosis, and it confirmed that this was a case of hereditary spherocytosis. The beauty about digital pathology is you can, post capturing the images, you can process it in ways that would make it more efficient and easy for you to look at. So digital pathology is whole slide image for sure. That's for purists of surgical pathology, but you can also use it in hematology, clinical pathology, for semen analysis and simple images of routine work processes like tube identification and all of those. So what did we do initially 10 years ago? We tried to understand the concept and components of digital pathology, whether it was hardware, microscope, computer, monitor, camera, look at the software, the scanning software, the viewing software, the reporting software. All of those need to be looked at. Validation and regulatory compliance, this will become an important aspect as we go along, because if we start using digital pathology and computational pathology as tools, our ability to be confident about the reliability of the result that we are giving to our patients becomes very important. Because once we have signed off the report, we really can't go back and tell the court that the digital pathology or the computational pathology gave an output, and that's the reason I have provided that. It would never be accepted in the court, because you take responsibility for what the AI provides. Training and competence will be necessary as we go along. So if you look at the pathologist and the slide, we were doing it using microscope, and in 2014 we got 13-14 we got our first scanner. It was completing one slide in 3 to 5 minutes, and that was not sufficient for us because we couldn't complete the day's work. It resulted in an increased turnaround time, stress levels increased. So there was need for speed. We brought in a second scanner. That was the first challenge. And even with the second scanner, it was not possible. So in 2015, we got a high throughput scanner. And even then there were challenges. The next one was traceability of the slide to the digital slide. So we had to improve our barcode. So we started looking at how to move from a 2D barcode to a single 1D barcode to a 2D barcode, and even look at what the barcode should actually have: the patient ID, the specimen ID, the block ID, stain ID, and the slide. So, and then now we have a QR code on the slide, which provides a lot of information to in the QR code. And then the third challenge for us was the software, IT, and the network. Of course, these are all relative challenges because these are more resources, and there are experts who are willing to take care of these things. But certainly, we should be aware of them. Storage is certainly a concern. The cost of storage on the cloud is always going to be there. We need to see how we can convert that into practice. So we're grossing station images, microtome, you can digitize every process and make it available for you in a way that it's seamless, and it's very easy for you to take decisions based on the digital data that is available. Just to share with you, this is one of the cases which Dr. Jairam is sharing with me. This is about 8 or 10 years ago, when there was a case, and his ability to show the slide. So it could be a multi-header microscope, but this was much more convenient. This was a liver mass, which he is demonstrating. He was showing me that the lining epithelium as well as the underlying stroma was familiar. Particularly, the stroma looked like that of the ovary. And this was a case of intrahepatic mucinous neoplasm with ovarian-like stroma, a rare, fortunately a benign but a rare entity in our practice. So when we introduced digital pathology in our workflow, errors in the upstream and downstream processes were amplified. So when we actually digitized our first few slides, the nicks and the cuts, the poor staining, all of those got amplified. The same slide, if we had put it under the microscope, it would have the same slide would have caused a problem, because the same slide would not have caused a problem under the microscope, because we are used to seeing the slide where even with nicks and cuts, we would see through those errors, and we would try to make a diagnosis. But when it comes to digital slide, it gets amplified, and it actually prevents you from making a meaningful diagnosis. That was the upstream challenges that got sorted out when we implemented whole slide imaging. And subsequently, after completing the diagnosis, our ability to dictate, report, and sign out was much easier. Just sharing with you some really scanner views of some lesions that probably, if it was under the microscope, you wouldn't be able to see such views. An eyeball showing the tumor. This was a soft tissue in the thigh. You can see the zonation, the hypercellularity on the left-hand side gradually maturing to the right side, to the periphery. This was a case of myositis ossificans. So there were challenges. Selecting the right scanner was a challenge for us. Hardware, software, LIS interface, workflow process, turnaround times, all of them were challenges. Speed of scanning, resolution, file size, slide pickup technology. Because about 8 years ago, this technology for slide pickup was from the top, where it would pick up from the cover slip. And if there was a mountain that was oozing out, it would cause a block in the movement. So those challenges were there long back, but now they are no longer those challenges because the entire technology of picking up the slide itself has changed. So scan speed at various magnification. We need to pay attention to these, at least from our experience. This is what we had looked at. And the possible challenges were slide pickup, image stitching, image load time, file size, image server issues, image storage. So unlike digital radiology, where films are redundant, in digital pathology, slides are the basis. The strongest ROI, like I said, is the innovation that happens as a result of digital slides. And of course, none of these have a direct impact on ROI as a financial metric. FDA has allowed marketing of the first whole slide imaging. This was earlier in 2017. Many digital imagers have now got that FDA approval, I presume. So use of digital pathology is in routine reporting, offers second opinions, telepathology, archiving and sharing, quality assurance and proficiency testing, image analysis, morphometry, artificial intelligence, education and conferencing, audit trail. So just to take you through, I'm coming to the end of the time, just taking you through different workflows that we typically do in conventional reporting. And when we replace it with a slide scanner, what changes? You can see that the slide making doesn't change. It's just that at the time of after the slides are prepared, it gets into the box, and then the viewing becomes that much easier. So I did mention that the digital pathology is beyond whole slide imaging as well. What are the challenges? Again, initially getting used to whole slide image, workflow adaptations, time taken to scan. In between, we had 4 or 5 years back, speed of scanning, LIS interface, and software workflow. Currently, the cost of acquisition, image management, and storage costs. So while on one side it has amazing potential, it's not without challenges, and that's what I would like to share with you. Risk management in digital pathology, lack of training may cause anxiety and stress. Due to scanning speeds, there could be delay in reporting. If network fails, the software will not work. Whole slide image may be suboptimal, so you need to rescan it. Identifying mitosis and granulomas may be challenging, at least it was for us initially. There's a learning curve for that. Navigating slide on screen may cause harm if you see that as one of the risk. So I had asked ChatGPT what are the key aspects of digital pathology, and it gave a whole lot of points, and it also gave me a pie chart highlighting which ones were the most important ones. So to summarize, digital pathology is here to stay. Digital pathology, at the very least, is a novelty, and at the very best is a tool for pathologists right now. The tool can morph into something that will assist pathologists and, in my view, will not replace pathologists. Digital pathology will become more relevant since computational pathology is built on digital pathology or whole slide imaging. New technology to acquire images will start coming in, and they're already there. Probably it'll be, we can discuss this in another session, because there are very exciting new technologies that are coming to acquire images. Digital stains, in fact, converting an unstained image and using staining the unstained image digitally is also being looked at. A lot of research is happening there. Morphometry algorithms for organs and diseases are coming in. With that, I would like to express my gratitude to Dr. Johnson and moderators of Pathoindia, and to all the members of Pathoindia for their participation. Thank you so much. And I will stop sharing, and I hope we can have discussions, we can have viewpoints if there are. Oh, I didn't see that. Somewhere in between, I think you could not hear me, is it? Okay. Are there any questions? Okay.
Good evening.
Good evening.
Thank you, sir. That was an excellent lecture, very concise and comprehensive all in one.
Okay.
It was very impressive to see the software that you use in your lab.
Okay.
I have a question. What is the status of, approved or established guidelines regarding the validation and use of digital pathology in the Indian scenario? Is there something going on or not? Like, I mean, uh, it's like,
I think that's a very valid question that's been there ever since digital slides have started to be used. Validation is essential as part of our reporting itself, and more importantly, as part of accreditation. So, validation is also gives you the ability to understand if the new technique that you are going to use is meaningful. Is it reliable? Is it precise? Is it consistent? Is it accurate? The process of validation can be different between labs, but there are clear guidelines coming from, say, CLSI or other guidelines from proficiency testing providers. And you can certainly use any of those guidelines as long as it is meaningful for your lab. If you want to start using digital slides, you want to first look at the glass slide, make an impression, and then look at the digital slide after a washout period. You wouldn't, because if you have seen the slide and you have a memory of it, it becomes easy for you to be biased when you see the digital slide. So you need to build a protocol on how you're going to validate digital slides in your lab. So it is that becomes the crux of the issue. But there are clearly there are many guidelines which will help you understand, and probably you could modify some of them to be adapted to your own laboratory.
Sir, can you suggest one or two?
I know.
I mean, sources of guidelines.
I think I know CLSI is there, but we many years ago we used a guideline from probably Europe that I don't have it offhand, but we completed this validation long back, and we have ever since been using digital slides. Of course, there have been times when there are challenges, but we have kind of done that. Since Dr. Kim is already here, I would take his help in answering that question from you, Dr. Hina. Dr. Kim?
Yeah.
Thanks.
So I think that there is a kind of general issue which keeps coming up about whether these technologies will replace us. And so we can look at the standards for using them, but we can also think about how our life in general is going to be changed by AI. Let's fantasize for a moment that we can control everything about our work life, even the future, right? But what about our life in general? Soon, at very little cost, or maybe no cost, we'll all have AI tutors, AI assistants. And so when you would have forgotten some important detail about somebody you meet on the street, you'll always have that detail because the AI will have anything that you've forgotten, and it's kind of a part of you, right? And it can remind you of all the healthy things you should be doing and so on. So if you think about that in the non-work part of your life, most people think they would always want that. They would never want to turn it off. So like right now, we don't have anything like that, but we will very soon. So, and this will spill into our work life. Once our personal life is so influenced by these AI assistants, then we'll say, well, why not have that in the workplace? Why wouldn't I want to be able to remember everything? Not just the things my stupid brain is able to come up with, but everything I should know. The AI can give me the information. and help me to eat better and exercise better, everything, right? So,
Yeah. I think what Dr. Hina was trying to ask was what would be the validation protocol to introduce
no,
digital?
I understand that, but I think it's too simple to think that that's the most important question, that we should, that there should be like an international protocol for how, digital pathology is practiced. And that's not the way most people are thinking about it. It's not digital pathology itself that is important. It's that you need to digitize in order to use AI. So it's the bridge to AI. You can't have AI influencing the workplace without scanning the slides, right?
Yeah,
So it depends upon much more than just the basics of sort of how we're practicing pathology. It's how we're
yeah,
practicing medicine in general, how we would integrate this with every other way that the patient's being examined. So it's a much larger question. And so it doesn't have a simple answer. And I don't think you would want that anyway. Suppose I
yeah.
told you, well, India should be doing exactly this. And if you're not doing exactly this, that's wrong. No, I think you should figure out what suits you,
Correct.
what pace and what aim, what you're trying to accomplish, and that would determine what standards you would set.
I think you have kind of summarized it very well. I think, Dr. Hina, the answer is there. It's about your intention to introduce digital pathology should look at all those aspects that ensure the reliability of the result that you're going to give. Dr.
Yes.
Anita had a very valid question. What has been the
Thank you,
most
sir.
frequent errors in diagnosis in histopathology? I think we did a study, and initially, like I said, we did miss mitosis and we did miss some ill-formed granulomas, but by and large, there were no major discordance. Minor discordance were there. I think the grades kind of changed between the glass slide and the digital slide, but those were also kind of, it did happen. Uh, uh, People who were well versed with the digital slides were much better than those who were new to digital slides. So I think there are multiple variables that are involved, and we need to keep all those variables in place before we actually decide on reporting only on digital slides. And Dr. Kim mentioned very clearly, the digital slide is only a means to an end, not the end in itself. So, and I think that's a very important point to keep in mind.
So you asked about my personal history, and that's kind of interesting that I have some of the earliest videos about whole slide imaging and so on. So you would think that the place in which I work would be in the forefront. But no, when I presented it here, people almost started crying. They said, "This will wreck everything. Our work life will be terrible. We'll all be unhappy." And I said, "Look, if you want, we can be the last pathology group to embrace this in Canada. We can be, I let everybody else do it first." They said, "Really?" I said, "Really." And that's kind of what we've done. That although I'm working on this and a sort of leader in our unit overall, we're not using it terribly heavily. I use it for, kidney pathology and for our rounds every single Friday, and I'm on call every fifth week. So every fifth week, I'm using it for sure, and doing cases at our biopsy conference, but a lot of the pathology practiced here all around me is not digital at all. It's very
Yeah,
old-fashioned, and people like that.
I
So
think
that's the honest answer. That
that's
I'm far in the future, but my colleagues aren't. Yeah.
that's interesting because I think you've provided that viewpoint, which all of us see in our own practice, that
Right.
some adopt digital pathology very naturally, very easily, but for
Right.
others, it is a very stressful transition to move from a easy analog slide working to a
Right.
monitor, because it involves the use of a computer, the mouse, the hand-eye coordination, all of those. So I think all of those are some variables that are obstacles to adapting digital. But I think I agree with Dr. Gaurav Jain. He's mentioned that you won't miss mitosis if you scan on 40 or 80. I agree with you, and I think that's a learning curve that we had. This is not now I'm talking about, this was initially when we introduced digital pathology, and it used to be scanned at 20x and zoom to 40x, but subsequently we realized that when we start scanning at 40x, it is much better, and we are able to
Yes.
identify mitosis. Yeah, thank you so much for that.
Yeah.
Limitations will reduce with time and technology, I agree. Then let me see. How does one go about QA, quality assurance of digitized slides? And Dr. Anita, meaning this is not a naive question, it's a very valid question. When you say go about QA of a digitized slide, the QA, there are two parts to the QA. One is the reportability of this digital slide itself. And I think that is much easier to handle because the reportability of a digital slide would be in parallel to the reportability of a glass slide. I would think you would be able to pick up noise on a digital slide far better than noise on a glass slide. So I would think that's something that we need to look at. On a daily basis, when we have a control slide, we should digitize the control slide as well. And then you would be able to record your data on the digital slide, whether there are nicks, cuts, staining, quality, all of those. When it comes to QA of the actual technical part of the digital slide, the resolution, the magnification, all of those, I am not clear on that because I think that gets into the technical domain.
So there's one thing there that has to do with the politics of, introducing this. If you force people to do it, don't explain why, but just say, from today, you have to do this, then they won't clean the slides. And you'll be digitizing dirt, dust, India has lots of that, right? So you'll get the best pictures of dust and dirt you've ever seen. If you don't handle the politics well, if nobody understands the way in which this is going to make things better, they only understand that they're being forced to do it, then they won't clean the slides.
I agree. I think that's the fundamental difference between training and education.
Yeah.
Education tells us why we need to do what we do. Training is just to see what and how we do stuff. So I completely agree with you. The entire QA purpose is to be able to report on the glass slide and to make sure the result is reliable. What is this? Yeah. Dr. Neha, do you have any comments?
Yeah. Thank you very much, Dr. Sujay, for such an informative presentation and for sharing all your experience over these past years, the way you have adopted the technology. So you mentioned, there is a learning curve, like mitosis you mentioned many years ago, it was harder. So my question is that, people who are going to start delving into this technology, they will have a learning curve. Do you think there are any areas where they may have to decide between that? Do I continue with conventional microscopy for this particular type of situation? And are there areas where digital pathology offers better evaluation?
So, in our experience, what we realized was we did not shift to digital overnight. I think there were many months or even years of parallel viewing. There are times when we were very comfortable with the glass slide, and then we started to look at the digital slide and say, okay, there seems to be some gaps here. Let us understand this. And we continue to use the glass slide for such instances. Till such time we became comfortable with that. Now, which are those instances where glass slide is better and which are, I think it comes with actually applying digital pathology in your workflow. Now, if the workload is very heavy and you do not have the time to do this kind of, it will take longer. It'll just take longer because you're so comfortable with the glass slide, you start being with the glass slide and you never adapt to the digital slide. But having seen my colleagues kind of take it to digital pathology like fish to water, it was so seamless. And at no point in time did I get a argument from them that they made a mistake because it was the digital slide.
Mm-hmm.
That was confidence. That was the confidence with which I'm telling you this, because it's pretty good now. They look at it on the screen, they're comfortable. I have not seen them look at the screen and say, oh no, I have to go back and see the glass slide under the microscope. I have not come across that.
So there are special cases like fluorescence, looking at immunofluorescence. You can do that digitally, but obviously it takes different conditions. And then cytology, anything where you're dealing with whole cells and focusing up and down, that's a different kind of scanning then that you need, and it will take longer if you want everything to be in focus. So there are those special situations that are clearly different.
I agree. You were mentioning something, Dr. Nee.
Well, thank you, Dr. Solis, for pointing that out. Yeah, my question related to this was, and you explained, both of you explained very well, was because people, when they will start adopting this technology, they do need that little bit that, okay, I can still hold on to my glass slide for a little bit, but start experimenting.
Yes.
I speak from my experience as an educator since I teach, and all our students are only used to digital slides because we have started only teaching them using digital images and not actual scopes. Of course, we do want them to look at a scope because ultimately they have to. But what I found was when I have been teaching them using digital images, they really say, what is the need of using this microscope? And I said, no, you have to at some point really look into it. But again, I just want to thank you for initiating this interesting topic, because technology is everywhere and we cannot escape it. And ultimately, everyone has to embrace it. Yeah. Excellent talk. Thank you.
Yeah, thank you. Thank you very much. If there are no further questions, I think we are gone past 15 minutes, gone past 1 hour. I think I must thank each one of you for your patience, and you've been an amazing audience. A lot of discussion happened. Thank you so much. Dr. Johnson, over to you.
Thanks a lot, Sujay, for that interesting talk. I think there's one more question left by Jyoti. If you can answer that, will a pathology be outdated?
Oh my! It's a. What do you mean by outdated? Meaning outdated or replaced? Outdated for sure, because if you don't catch up with what's happening in technology, you will be. So I'm outdated because I am not on WhatsApp. So if you think on those lines, then if you're not adapting to digital pathology, in a couple of years, there would be tools that would be using whole slide images. And if you have not been part of that journey where we will be using digital slides, we will be outdated. So I would think AI will not replace pathologist, but pathologist with AI knowledge will replace pathologist without AI knowledge. That's my view. Can DICOM compression be used like radiology? I think a lot of discussion has been around this. Deduplication is one of the technologies that have been considered to compress digital slides, whole slide imaging, because they are very heavy. Because in a whole slide image, there is really no duplication of the pattern. Deduplication has not seemed to work. I'm not sure how technologies right now are compressing and storing. And even if they compress and store, when you actually open such compressed images, will the resolution continue to be there or the clarity continue to be there? I think that's still a question. We are still working with heavy images, particularly if it is scanned at 40x. So you, Dr. Anita, are you talking from the storage point of view, or are you talking from the viewing the slide point of view? Storage, yeah. I think we are still struggling there because it costs to store. And right now, our biggest obstacle is because we handle about 250, 300 slides a day, we are finding it extremely difficult to store all of them on the web, on the cloud, because the cost has gone up considerably. And we have to store it for a good number of years as well. So Samiksha had, it will in future, it will definitely replace pathologists. We are already replaced by technicians. I think Samiksha has gone extreme. No, I don't think AI will replace pathologists. It will only morph. The pathologist has to reinvent himself to be relevant with the AI around. And that's very important for us to understand. Dr. Johnson, I think, can we wind up? Everybody's...
Okay, that's fine. Any more questions from anyone? Can I request some more questions, please?
I think it's 20 minutes past 1 hour, Johnson.
Okay.
Scheduled 1 hour and it's gone past that. So it's been wonderful participating. Thank you, Dr. Johnson. And thank you, Dr. Kim, for your excellent views.
Sure.
It's wonderful. And Dr. Neha and everyone on the chat, Dr. Anita, for those very, very relevant questions I see in the chat box.
So thank you, Sujay, for the interesting talk once again. Look forward to more interesting sessions.
Yeah.
And thank you to Dr. Kim for a special guest today. Thank you, Dr. Neha, and everyone out here. Hope this is the very first Zoom we had on Pathoindia. Looking forward to having such more in the future, inviting more speakers and more sessions from Dr. Sujay, of course.
And Dr. Johnson, I think we have Dr. Manoj Singh online. Thank you, sir.
Yeah, just joined in, Dr. Manoj.
Yeah. Amazing to see a senior pathologist of India come on.
Precisely on time. I was having, connectivity problems. But
okay.
Great
Okay,
to
sir.
see you guys.
Okay, sir. Thank you so much. Wonderful to see you.
So,
Thank you, Dr. Manoj, for joining in at the last moment, but thank you again.
Yeah, thank you very much.
So thank you all.
Bye-bye.
And have a nice day. Goodbye.
Good day. Good day. Bye.
Bye.
bye. See you all.
See you.
Bye.
Congratulations.
Thank you, sir. Thank you.
Bye-bye.